Afternoon, everybody. Welcome to today's webinar. I'm Paul from Foundations, and special webinar today. So none of the usual bits and pieces, but very pleased to have Dr. Rachel Russell from University of Salford to come and speak to us about various outcome measures that can be used for home adaptations and disabled facilities grants. So without further ado, I will stop sharing my screen and hand over to Rachel.
Welcome everyone to this workshop on outcome measures and their relevance to the DFG process. This is the first time I've ever done this session, this workshop as a webinar, so please bear with us as we kind of learn together. Hopefully we'll be around about 90 minutes, but if anybody knows me, it could be a lot longer than that, but honestly I won't go on it any longer than 90 minutes. Yeah, as Paul says, I'm currently working at the University of Salford. I'm an occupational therapist by background, for those of you that don't know me, but come this Friday I'm actually leaving Salford and I'm actually going back into clinical practice. I'm finally getting to practice what I've been preaching for the last 10 years. So that's a little bit about me. So in terms of what we're going to do, or what we're going to be covering this afternoon on this workshop is, obviously, as you would expect on a workshop around outcome measures, part one is kind of going to be some of the theoretical bits and pieces. So spend a little bit of time describing obviously what an outcome measure is, explain why it's really important that why we should be measuring and need to measure outcomes in terms of the DFG process, and particularly around not only for ourselves as practitioners, but also why it's important for customers that we're measuring outcomes, for ourselves, as I said, as practitioners, for home improvement agencies, occupational therapy team, and as commissioners. And then we'll be looking in terms of outcomes, actually, what kind of things can we be measuring from the DFG process? We'll have then a little bit of a break, and then we'll go on to part two, which is a little bit more of the kind of practical side of using outcome measures in practice. So we'll be thinking about what some of the practical challenges are of measuring the outcomes, signposting you to a range of tools that I know from kind of collaborating with practitioners out there are currently being used to measure outcomes from the DFG process. Now, the challenge I've got here is and this is one of the challenges with outcome measures that we'll talk about, I've got to obviously not infringe on copyright, so I will signpost you to websites where you can actually go have a look at the tools. But I'll talk about 4 tools that are currently being used and just what they measure. And then we'll just talk a little bit about how we can use that data to support commissioning and service improvement and development. What I want to do first of all, as we're kicking off, would be really useful for me to just get a feel for who you are, the audience out there, just so that I know that I'm pitching it right. So hopefully, with the magic power of technology, I think Paul has got a little poll.
Yep, there you go. It should have popped up for you now if you're using Zoom.
I can see that, marvellous.
If it hasn't popped up for anybody on Zoom, then it's probably the pop-up blocker in your browser. There'll be a little icon you can click on to be able to unblock it.
Brilliant, Paul, thank you.
So I think we're nearly there already. Just the last few people to vote.
Will I be able to see the results then when you click some magic button?
Yes,
right, okay. I won't panic then just yet.
Okay, I'll give it 5 more seconds. 3, 2, 1. There we go. So
right, lovely. So we've got majority of people who have OTs, sorry, I'm using two screens, so if I'm looking over here, that's why, because I've got a screen over here. So we've got OT, managers, technical office. Also, we've got a real kind of good balance of audience, so it's not just OTs, it's a good range of folk out there. So hopefully, obviously I am an occupational therapist, so and I'm obviously an occupational therapy academic at the moment, so some of this presentation will come with that slant, but hopefully it will still be relevant in terms of what I've got to say. And certainly when we've done this workshop with housing colleagues for foundations, they found it really useful. Right, so let's get down to basics then. First of all, what is an outcome measurement tool? Okay, so first of all, an outcome is the impact the service intervention has on health and well-being. Okay, so that's what an outcome is. So we're looking at the impact that that service, that intervention has on health and well-being. So therefore, it makes sense that an outcome measurement tool measures the impact of that intervention service on health and well-being. Okay. And usually what happens is that the same tool or tools, because it may be more than one tool that you're using in terms of outcome measures, you're using the same tool to measure the intervention pre and post the intervention. So you're using the tool before you carry out the intervention, and then you're using the tool post intervention. And the difference between those two figures should be the impact that the adaptation intervention has had on health and well-being. So hopefully that's fairly basic. The other thing I should have said is if you want to ask questions, I can't see the chat box, but Paul, if you could come in with any relevant questions, or we can save them to the end, is that okay?
Yeah, that's fine. I'll keep an eye on the chat box.
Brilliant, thank you. So that's what an outcome measurement tool is. Right, so that all sounds really simple, but it is, when you start unpicking it, it is actually more complex than it first appears, and that is because of these three questions. Firstly, outcomes are about impact of the intervention, but how do we think of the DFG process as a health and social care intervention? And actually, what impact can the DFG process have on health and well-being? Health and well-being covers a huge range of concepts. So actually, what impact can the DFG process have on those different concepts of health and well-being? And actually, outcomes are of interest from different perspectives and can be collected from a number of perspectives. And I'll unpick that in a little while. Just to go back to that first question, actually, how can we think about the DFG process as an intervention for impacting on health and well-being? My PhD was around the DFG process and the role of occupational therapists within that DFG process. And one of the things that I looked at is actually how can we think about the DFG process as a health and social care intervention? And I think what my feeling and my perspective is that through the DFG process, what we're doing is we're using design and construction techniques and processes to improve the health and well-being of individuals. So through the installation of grab rails, stair lifts, ramps, the big extensions that we're doing, we're using lots of design and construction techniques to do that. And we're using those design and construction techniques to improve the fit between the built aspects of the home environment and the person. So as an occupational therapist, and as you'll all know because you've got an interest in adaptations, we all know that the way that home environments are designed, there's often a lot of architectural barriers within that environment that stops people with a range of motor sensory processing impairments doing the everyday activities. So what we're doing through providing those adaptations, we're removing those barriers and we're improving that fit between the person and their home environment, so that they can do those everyday activities that are really important to them, that contributes to their health and well-being. So I think that's how we can think about the DFG process as an intervention, because we're using design and construction techniques and processes to improve that fit between the person and their home environment, so that they can get on and do the everyday activities that are really important to them. So again, that sounds relatively simple, but I think one of the challenges that we've got in this area of the DFG is, unlike other areas of health and social care, this intervention, if we think of the DFG as an intervention, involves a number of services and professionals. Not only that, it's interdisciplinary. So unlike other areas of health and social care where we're measuring impact, when we're looking at the impact of the DFG, we're actually reliant, when we're looking at measuring outcomes of the DFG process, we're really reliant on collaboration across housing, health and social care. So I think that's one of the challenges, yet opportunities also, is that, you know, it is an interdisciplinary intervention, and as we know from the DFG review, involves numerous professionals and often a number of services. So I think this is why you can probably see, if you've got an integrated service, that some of those barriers are naturally reduced. Okay, Paul, are there any questions that are cropping up?
Not yet.
No, lovely. Okay, I don't know if people agree with that, and that being one of the challenges in terms of measuring outcomes is the fact that it does involve a number of services and professionals. So I just want to, I think sometimes we really forget the fantastic stuff we can do in terms of improving health and well-being through the DFG process. I think all too easy, it's very easy to take a very kind of medical model and think about, you know, independence in personal care and function. But I think if we think about those broader aspects in terms of health and social care, health and well-being outcomes, you know, I think the DFG impacts on a variety of aspects of health and well-being, and that's very much kind of aligns with what we're trying, what the flavour of the Care Act is. So just think about what impact, and if you just use the chat box now, just to put some ideas that come into your head, you know, from the DFGs that you have done, what kind of impact have you had on the health and well-being of the people that you've been working with? And if Paul can read them out to me, hopefully somebody's going to put something.
Prevention and independence.
Brilliant. Yeah.
Holistic needs.
Yeah.
Quality of life. Reducing the need for formal care. Access to toilet and bathing. Access to work, family life. Valued to be listened to, remaining in own home, lifting depression, safety, reducing risk of admissions, preventing falls, increased dignity, restores confidence, self-esteem, prevention of falls, keeping children safe, prevention, access to basic needs, peace of mind.
Brilliant.
Enable someone to do what they want to when they want to do it, feeling less disabled.
It's just what we can achieve, and I think sometimes we don't, certainly with commissioners, the public, I think sometimes it's about really raising that awareness that it's not just about promoting independence, it is the wider aspects that it has, the wider impacts it has on health and well-being. So I think this is my little list in terms of kind of me reflecting on my own practice. Like I say, it's not an exhaustive list, and I think you've kind of covered most of this. Obviously, I think the first thing that we always think about is that in terms of outcomes, the DFG is very much about improving, restoring and enabling functional independence, and that probably comes through in terms of the legislation that the DFG sits within. It's about reducing the impact of motor processing, sensory and communication impairments, and by doing that we decrease disability, or the impact of disability. Huge impact in terms of what we can do through the DFG is around reducing and preventing accidents and falls. Always a tricky one to be able to measure in terms of outcomes, because obviously how do you know whether you've prevented a fall or not? Preventing hospital admission, obviously being a real key element during COVID-19. Prevent admission into residential care. Yeah, I think that speaks for itself. And then these are some other aspects. Facilitating family life, that importance of, if we can make areas of the home accessible for the whole family, that importance of a child being able to be part of the family. Restoring and maintain dignity, which has been mentioned, and I think that is something that very much came out of Francis Haywood's work around the DFG and major adaptations, the impact it has on restoring people's dignity, you know, just being able to go to the loo and not have to go on a commode to the loo. Next one links to kind of falls. What we know is if people feel confident within their home environment, that then has an impact on reducing risk of falls and keeping people independent. So if through the DFG we can keep people feeling independent and confident, then we know it has an impact on independence. Sometimes a bit of a controversial area, but play has such an important part, plays such an important part in terms of health and well-being of children. So if we can create access to play environments, and that has a huge impact in terms of health and well-being. Obviously, kind of the secondary impacts of DFG is that we can provide, by enabling people to get out of their home environments, or to be able to get themselves washed and cleaned and ready in the morning, it means that we can give them access to paid employment, access to education, access to community care services, providing access to outdoor space. We know what the evidence says in terms of the impact being able to get out and about into gardens, outdoor space has on health and well-being. Again, being able to get out and about reduces social isolation and loneliness, and we know the evidence base in terms of if people are feeling lonely and isolated, the impact that has on health and well-being. And I think the other thing that we need to think about is that, you know, for a lot of certainly for a lot of formal care is actually now people's home environments are workspaces, and the DFG plays an important role, particularly around moving and handling, to ensure that we're creating spaces that make their tasks easier to perform, so that hopefully what we're doing is also reducing work-related injuries for those carers. So obviously having an impact on both the health and well-being of informal and formal carers. Okay, so there's huge impact and outcomes that we can achieve from the DFG process. So just moving on, I said earlier that one of the challenges that there is that outcomes can be measured from different perspective, and I just want to talk a little bit about this. Obviously from the service user or the customer or whatever we call people that we work with, what in terms of impact and outcomes, I would imagine as a consumer of health and well-being myself, is what I'm interested in is, you know, when I go to see the doctor, you know, or another health professional, what I want to know is, has it solved the issue that I was having, and am I satisfied with what's being done? So from a service user and customer level point of view, I suspect and suggest that is the impact, the outcome that they're primarily interested in terms of the DFG process. From a professional level, okay, so as I say, I'm an occupational therapist background, and I have a professional duty to measure the outcome of an impact of the interventions that I provide. So I've actually got a professional duty to measure the outcomes of the DFG process that I might be involved with. So from my perspective as a professional, I'm interested in whether that intervention or the service that I'm a part of has improved that person's occupational performance, has improved their ability to carry out and perform their everyday activities, whether the person is satisfied with their the way that they're carrying out their activity, and whether we've had an impact on participation, health and well-being and quality of life. So as a professional, that's what I'm interested in terms of outcomes. At a service level, so at that management level, what you're probably interested in is, are we doing what customers and service users and commissioners expect we should be delivering with obviously the resources that we have? And that's obviously going to be shaped by service level agreements, KPI, and very much kind of performance and process driven. From a commissioning point of view, what you're interested in is whether the services that you are commissioning and the interventions that they're providing, are they being delivered in a cost-effective way, and are they providing health and social care outcomes in a safe and cost-effective way? And let's not forget government and at that policy level. Obviously at that government level, obviously there's a huge amount that's been invested in the DFG, so what they're interested in at that government policy level is actually, are we improving the quality of life and health and well-being of the population through the DFG? So as you can see, I think the challenge then is, challenge number 2 is, it's about finding a tool, and I don't think it's probably possible, but finding a tool that enables us to capture outcomes from those different perspectives. So that's what I'm trying to illustrate by that slide there. Paul, is there any questions that have cropped up?
Sorry, I couldn't unmute myself for a second.
Sorry, I was like thinking, oh my God, have I gone off? And it's just complete silence, and I've just been talking for the last. There's no questions that have cropped up, have there?
There was somebody asking about a reference for Francis Hayward's work.
Right. What I will do is I will pop up some. Actually, in chapter 11 of the DFG review, I've referenced Francis's work in terms of what we should be thinking about in terms of necessary and appropriate. So if you have a look at the DFG review, it will be referenced in the big document, and I think it's chapter 11, but I can also provide references as well if you email me, and I've got my email at the end. Is that okay?
Yes, yeah, no, the bit you mean.
Yeah.
And are you happy for people to have the slides afterwards?
Yes, I will send the slides through, and hopefully Paul can circulate them.
Yes, I've already got them. Yep, that's fine.
Right, brilliant, lovely. Okay, so what I just want to do is just take the next few slides just to talk about what's happening at that policy level in terms of what is influencing what's being measured. Obviously, if you're a manager and commissioner, you're probably very aware of what's happening at that policy level. At practitioner level, I think it's always just really worthwhile knowing what is driving managers and commissioners in terms of what outcomes they're interested in. And obviously what they're interested in is in terms of what they're expecting to be report on in terms of the policy level. So what I'm trying to argue is that policy level really influences what commissioners and managers are being asked to measure. So some of the key kind of documents to be aware of, and I'm just going to go through these in a bit more detail, is the Adult Social Care Outcome Framework, and I've got the links here for you, the NHS Outcome Framework, the Public Health Outcome Framework, and the Better Care Fund metrics. So if you understand what these frameworks are interested in, it will help you understand the kind of data that you can perhaps be looking at producing that will help you give the data in terms of the outcomes that you're having on health and well-being. So as I said, I'll just quickly go through each of those frameworks so you've got a sense of the kind of outcomes that at that policy level is being asked for us to look at. Obviously around adult social care outcomes, it's around the key aspects around enhancing quality of life for people with care and support needs, delaying and reducing the need for care and support, ensuring people have a positive experience of care and support, and safeguarding adults with circumstances that make them vulnerable and protecting them from avoidable harm. So anything that the DFG, and we saw that huge list, and I think we can make some links from that big list in terms of the impact that we can have. So any outcomes and impacts that we can show that the DFG is having on those concepts, those factors is going to be useful for you in terms of demonstrating the positive impact that you're having on health and well-being. In terms of the NHS outcome framework, so the overarching outcomes there are preventing people from dying prematurely, enhancing quality of life for people with long-term conditions, helping people to recover from episodes of illness or following injury, treating and caring for people in safe environments and protecting from avoidable harm. Again, I don't think it takes a lot of imagination to begin to understand from a DFG point of view the impact that we're having on some of those outcomes, or how we can demonstrate the DFGs having an impact on those outcomes. In terms of the public health outcome framework, we have overarching outcomes that include improving the wider determinants of health, which we know housing plays an important part of that, and we know that the impact that poorly designed homes have on health and well-being. Health improvement, health protection, healthcare, public health, preventing premature mortality. Again, I think certainly around the wider determinants of health, I think we can all see the outcomes that the DFG can have on those aspects there. So the Better Care Fund metrics, probably really important for the DFG because that's where the DFG funding sits. So the overarching outcomes there that the Better Care Fund metric picks up are a reduction in the number of unplanned acute hospital admissions, delaying and reducing the need for care and support. Key one for the DFG here, when people develop care needs, the support they receive takes place in the most appropriate setting, enables them to regain their independence and effective joint working of hospital services and community-based care in facilitating timely and appropriate transfers. Again, obviously the DFG sits within the Better Care Fund. So obviously this has a huge impact in terms of the DFG and some of the outcomes that we should be demonstrating through the DFG. Okay, so I'm sorry if that's a little bit of whether you already know that, but I think it's really important that we understand from that higher level what data government managers, commissioners are interested in, and begin to make the connections between the outcomes that we're producing through the DFG to those factors. Hopefully that makes sense. Foundations, in one of their reports, and I'm sure Paul will come in because really sorry Paul, I forgot the name of the report, but within the report DFG came up with some recommendations around some of the outcomes that we could be measuring at a service level. So foundations have suggested that we could be looking at work that's allowed people to return from hospital, so data around the number of people that have been able to return home through DFG, reduction in cost of care packages following the DFG, and there's numerous examples now, particularly around single-handed care. And I'd point you also to the RCOT campaign, Improving Lives and Saving Money. Again, on that website, there's a number of examples of how OTs involved in the DFG process have been able to reduce care packages, cost of care packages. Look at work preventing admissions to long-term care and work carried out to expected to prevent falls. The reason I've got that in italics is that I think from an outcome point of view, those are really different outcomes, difficult to measure outcomes that are potentially preventing these issues. Then we've got how the DFG has improved health and well-being following the work for the people that we're working with, and then carers reporting improvements in health and well-being following the installation of the adaptations. And the reason I've got these in red is because when we start looking at some outcome measure, these are going to be the outcomes that I kind of focus on. And then the final one here that Foundations has suggested is the number of people helped in previous financial year who are still living at home. Okay, Paul, can you remember what the name of the report is? I'm really sorry, I forgot. I just can't bring it to
remember off the top of
mind.
my head.
All right, sorry, Paul.
It's okay.
I think
there's kind of, I guess, a couple of questions linked to this in terms of some outcomes, I suppose, are what the kind of customer or service use from the customer or service user's perspective, and some of them are more from the, I guess, kind of public sector or the provider's perspective.
Yeah.
Did you have kind of, I suppose you've kind of highlighted the ones that are more service user perspective. Do you see those as kind of the more useful ones?
I think I've got this on a slide in towards the end, because it's looking at outputs and outcomes. So I think in terms of things like work allowed return from hospital, I think those are very much outputs in terms of the numbers that you've actually achieved and how many people returned home. What it doesn't say is actually what impact it's had on improving health and well-being, which is about much more about the impact and outcome, which is very much those in terms of those that are in red. Does that make sense, Paul?
Yes, absolutely.
So it's outputs, which is more about the process as opposed to the actual impact that we've had on health and well-being. Okay, right. So I have been talking for, can you believe it, 35 minutes. We're going to take a quick 5-minute break because I've talked an awful lot at you. Has anybody got, before we move on to kind of the practicalities, has anybody got any questions?
There was one about, and this again may come into the practicalities, I think, between in two-tier areas where the council perhaps doesn't have some of the kind of more person-centred information to measure the outcomes particularly well. And
I think that comes back to that earlier slide about one of the challenges is that because we're measuring the intervention, that's where it gets tricky, because it's relying on everybody kind of collaborating and working together and having input. And I will pick it up in the practicalities bit. But I think that is one of the challenges that we've got in this field of practice, because if you are the housing team, you're probably relying on, in terms of, you know, what improvements we're trying to achieve through the adaptation, and it's whether you get, you know, and it may be the OT that's measuring it at that initial point, and then at the end. So I'm waffling now, aren't I? If I'm making sense. I will pick it up in the second part anyway.
I think most of the rest of the questions are things you'll be covering later on. So,
right. What I will do in our 5-minute break, I will go through the questions just in case there's anything that I've not picked up. So if we have a 5-minute break and come back at about, if I said 22, Paul, does that make sense? Would that be okay? Yep. And what we're going to be doing in the second part is just thinking about some of the factors that we need to think about when we're selecting a tool, some of the practical issues that you need to consider. I'm going to signpost you to some tools, and then we're going to think a little bit about using the data. So if we can come back for about, as I say, about 22-3, that would be grand.
Okay, thanks, Rachel. See you in 5 minutes.
Thanks. Paul, do you make it about 22?
Yep, just after. Yeah.
Right, am I all right starting?
Yeah, I think so.
Is that okay? Paul, can you actually see me on the screen?
Yes.
All right, that's fine. It's just I'm going to hold something up in a minute. Right, so the next half an hour is we're just going to talk a little bit about the practicalities. Again, ask questions and I'll answer them. Oh, just to pick up, I went through the questions and thank you, Paul, for answering some of them. Somebody asked about safety adaptations and learning disabilities. I'm right in thinking, Paul, that you guys at Foundation are doing some work around this?
Yes, we've got a draft report that's being done at the moment.
So I'm not right sure who put that question there. So it's a case of just watching out because obviously foundations are doing some work around there. Somebody also kind of mentioned around whether we should be foremost looking at outcomes from the service user's perspective. Certainly from an occupational therapist, I would say yes. But again, I'm not always, there's very little evidence and we need to do much more work around actually from a customer's point of view what is really important to them in terms of the adaptation, because I think sometimes that could be different perhaps from my perspective as an occupational therapist and as a technical officer as well. So I think there's some co-production work that we could be doing around actually what is really important to the people who need the DFG. Right, so practicalities. As I say, we're going to talk about factors to consider when selecting a tool, other practical things that we need to consider. I'm going to signpost you to 4 tools that I know are being used out in practice and just begin to think about how we can use some of the data in terms of using it to promote what we do through the DFG process. There are, if you're a member of the RCOT, the Royal College of Occupational Therapy, there are lots of resources that you can look at around outcome measures. From an allied health professional point of view, the Allied Health Professional Outcome Measures UK Working Group, that's a bit of a mouthful, produced a really good document in 2019 around questions to ask yourself when you're choosing an outcome measure. And again, what I will do is I will circulate the link to this because it is available. It's open source, so anybody can access it. Okay, so some things to think about. Factors to consider when selecting a tool. I think the first thing you need to do is think about actually what data you're already collecting that measures impact of what you do. There is no point starting looking at an outcome measure because it could be that the data you're already collecting could actually show some of that impact, certainly around outputs. So I don't know whether in the chat box you might want to just kind of put what you're already using. What might be interesting is if you put in the chat box if you're using any outcome measures at the moment or what data you might be collecting, just so that you can give your colleagues an idea of what you're already collecting. So I think it's about, you know, not reinventing the wheel. Look at what data you're already collecting, and does some of that data actually demonstrate some of the impact that you're having through the DFG. And some of that data you might already be collecting because you're needing to report it to commissioners, or you may kind of do audits, that type of thing. So yeah, don't reinvent the wheel. Have a look at what data you're already collecting that might help you demonstrate some of the impact that you're already having in terms of the DFG. Probably linking to the question that the person asked in terms of putting the person's perspective at the fore is the next question you need to think about is actually what impact on health and well-being do you want to measure. As we saw in the previous slide, we know that the DFG process can potentially impact on lots of different aspects of health and well-being, and actually what impact are you wanting to collect data on. And I think this is where collaborating with key stakeholders, including customers, will help to perhaps narrow down actually what impact do we want to focus on in terms of the impact the DFG is having on health and well-being. Again, that's going to link in terms of what you've been asked to measure through the different things that you're reporting on. So yeah, what impact on health and well-being do you want to measure? And again, I think this is something that you need to do in collaboration with key stakeholders around actually what is important that we should be measuring. In terms of what we can measure and the outcome measurement tools that are out there, this is based on some work by Liz Ainsworth, who's an Australian research around adaptations, and what she's done is categorized outcomes into outcome measures into 5 categories. So what she's saying is that there are outcome measures that can impact on accessibility and usability of the home. These are often checklists, so how many kind of falls risks are there before the adaptations. Now that we've done the adaptations, how many falls risks are. So that there are outcome measures that look at accessibility and usability of the home. And as I say, they very much focus on kind of risk and safety. There are some specific tool outcome measures that look at impact on what we call occupational performance and satisfaction. So these are outcome measures that measure the impact on a person's ability to carry out their everyday activities that are important to them and how satisfied that they are in carrying out those activities. And as I say, that's done pre the adaptation. So, how well are you performing this activity? How satisfied are you doing carrying out that activity? You do the adaptation and then you do the outcome measure again. And hopefully what you'll see is that the adaptation has had a positive impact on the person's ability to perform the activity and also how satisfied they are with the activity. That there are outcome measures that measure impact on functional independence. So these are things like Bartel Index. So kind of, how independent are you in activities of daily living? There are outcome measures that are about self-reported health and well-being and quality of life domains. So this is where the person is reporting what impact the intervention has had on health and well-being. So it's not measured from my perspective, the professional, it's the person themselves reporting using the outcome measure tool to say what impact it's had on their health and well-being. And the ASCOT tool that I'll show you in a moment is a tool that's used in health and social care that is a self-reported health and well-being tool. And then what impact it's had on the person's or the carer's functional capacity and capabilities. So that's again kind of very much thinking about function. Okay. So those are 5, like I said, there's hundreds of outcome measures. The Centre for Ageing Better produced a database of outcome measures, obviously with it being Centre for Ageing Better, obviously the outcomes around older people, but as I say, there's hundreds of outcome measures, and this is one way in which we can categorise and think about what the outcomes are measuring. Right, so as I say, we've got all those different types of measurement tools. So when we're choosing the tool, what should we be thinking about? So these are just some top tips. What we need to think about is whether the tool is going to be suitable for all service users that you work with. I think unlike other areas of intervention that is around a very specific condition, the great thing about housing adaptations is that housing adaptations can be used for an intervention for a diverse range of people, a diverse range of conditions. And not only that, we're using adaptations with a diverse range of cultures and background. So when you're thinking about a tool, what you need to ensure is whether that tool is going to kind of meet the needs of all your service users, or whether you need a tool that is more specific for one condition or one group of people that you're working with. So for example, if you're working with children and adults, it may be that one of your outcome measurement tools isn't suitable for children. So as I said, this is one of the things that we really need to think about is the tool that you're going to choose going to be suitable for all service users, or are you going to have to use more than one tool? And that's because, as we know, adaptations are fantastic because we can use them for a range of conditions and from people from a range of cultures and background. The other thing that we need to think about is in terms of outcome measures, you can develop your own homegrown tool outcome measure. But often what commissioners are particularly looking for are tools that have been validated and are reliable. So that basically means, does the tool measure actually what you might wanting it to measure, and will it produce the same results whoever's doing the measuring? So if I'm carrying out the outcome measure with somebody before and after the installation of an adaptation, if Paul was to go out and use the same tool, would he get the same measurement? So that's another thing that you need to think about is, does the tool measure what you want it to measure, and is it reliable in terms of will it produce the same results whoever's doing the measuring? And also, is whatever you're using sensitive enough to detect change? I think often what we can find, particularly around quality of life, we are aware that the adaptation can have a huge impact on quality of life. But if your tool isn't sensitive enough and doesn't ask the right questions, you won't detect the change and impact that you've had on quality of life. A good example of that is kind of, I suppose, quality of life around, you know, the adaptation being used to promote family life. If your tool doesn't pick that up, then you're not going to show that impact. So as I say, your tool needs to be sensitive enough to detect the change and impact that your DFG is having. Okay. Some other things to think about is, whatever tool you're using, you want it to support and enhance practice and service delivery. One of the key things about outcome measures is that you want to get everybody on board in terms of using the tool. So I think what's really important is that the tool supports your service delivery, supports the way that you practice, supports your assessments, supports what you're doing, and that it's not seen as another level of bureaucracy. If practitioners, if people see it as just another level of bureaucracy, they're not necessarily going to be engaged with the tools. So when you're selecting an outcome measure, I would be suggesting that you use a tool that's going to support and enhance what you're already doing and supports the delivery of service and isn't just another tier of bureaucracy. Another key thing, and I probably hear a collective groan now, is how and who will collect the data. And as again, this goes back to that earlier slide around, you know, the DFG process involves number of services, and who it may be the person collecting data at the beginning isn't necessarily going to be the person collecting data at the end of the process. So, you know, you're going to need to collaborate. And obviously, if you're collaborating, if you're using a tool, is the IT systems going to be compatible between you all who's collaborating on the use of the adaptation? And I know we already are aware of integrated services and some of the challenges that the IT systems have in terms of services integrating. The other thing that you need to think about is, do you require a license to use the tools? So the COPM that I'll talk about, you need a license to use the tool. You need permission to use the ASCOT tool. So that's why I can't show you some of the tools this afternoon. So one of the key things that you need to think about is, does the tool require a license to use it? And those other costs that might be associated with the outcome measure. So if you're adopting an outcome measure, you need to take that into account as part of your kind of setting up costs. So do you require a license to use the tool? Kind of going back to my initial point around the previous point that I made around, you know, what health and wellbeing outcomes do you want to measure? You also want to make sure that you're using a tool that your key stakeholders recognise. So if you're measuring health and wellbeing, that those are health and wellbeing domains that are important to your customers, that if your commissioner recognises certain tools that you use those outcome measures that perhaps the key stakeholder recognises as well, because that gives more power to your elbow if you're using data from tools that the stakeholders recognise and agree with. Or it could be that you need to do a little bit of education around with your stakeholders around why you're looking at those specific domains around health and wellbeing. A real important factor is training. Some of these tools require training and ensuring that people are competent in terms of using the tools. So what initial training are you going to have to do with staff, and what ongoing kind of support will staff need to be able to use the outcome measure? So you need to think about any training needs that you have. And also governance, the whole issue around quality control, ensuring that you've got those mechanisms in place to ensure that the outcome measure is being used correctly, and that you're ensuring that everybody's using the tool correctly. So yeah, you need to think about governance and having those mechanisms in place when you're introducing an outcome measure, or you're thinking about bringing an outcome measure into practice. My suggestion is that you sit with your stakeholders, you sit with your colleagues, and you sit down and you have a discussion around those questions. As I say, this is a really good document in supporting choosing an outcome measure, but it needs to be done in collaboration, and we need to have everybody on board in terms of what tools we're going to be using. Right, is there any questions around some of the practicalities? Paul, is there any questions that have come up?
There's a few people talking about a outcomes tool I got, I think it was in West Sussex. Let's have a look. And there's, I suppose, a few questions about exactly when you ask people their outcomes, whether you do it kind of straight away or wait for a little while, or is there a kind of best time to ask?
About the, I just think if you're bringing it in, it needs to be, you do it kind of, I would personally, if I'm doing it, I would do it from the beginning. I think you need all the stakeholders, everybody on board, before you start thinking about outcome measures, because I think it has to be done in collaboration. We need to make sure that we're all happy with what we're using. We all have an understanding of what we're using and why we're using it. And I think you need to get everybody together earlier rather than later.
Yeah. And then there's a few people saying that they got forms, and if anybody wants to send them in, I'll collate them and we'll circulate them.
Oh, that'd be brilliant to have a resource like that. Okay.
Yeah, I think that's probably about it for now.
Right, okay. Right, so these are 4 outcome measurement tools that I know that are being used out in practice. As I say, because of copyright issues, I can't share them with you, but I have provided you with links that will take you to the websites where you can have a look at these tools. The first tool is a tool that is an occupational therapy tool. I do apologise to those of you who are non-OTs. I do know it's used out in practice, and the reason I've mentioned this one is that for me it really measures the impact that you're having on, or the impact the adaptation is having directly on the issues that the person has identified. As a tool, what you basically do is, as part of your initial interview as an occupational therapist, you talk with the person, understand what issues that they're having, which is what we talk about, occupational needs. So you understand what their needs are. You get them to rate how they feel that they perform that activity and how satisfied that they are with that activity. And you do that doing the adaptation, then after the adaptation, and hopefully what you see is an increase. I think personally, this is Rachel Russell speaking, I think it's a relatively easy tool. The issues are, it is a license, it is an occupational therapy tool, so in terms of collaboration and working across professional groups, this could be a more challenging tool to use. The goal attainment scale is, again, another therapy scale. It's quite a simple tool, because what the patient basically says is they state what they want their goals and outcomes to be from the intervention that you're providing. And again, they kind of give that a score. Pre and post the intervention. I know the goal attainment scale is used quite a bit in paediatrics. So I know in Liverpool, if we've got anybody from Liverpool, I think they use that, the paediatric team use that quite a bit in with the children's, the goal attainment scale. Again, it's a tool that I think you could incorporate fairly easily into practice, because really we should be talking to our customers, the people that we're working with, around, okay, if we're doing this adaptation, you know, really what we're trying to achieve here, what are the goals, what outcomes are we trying to achieve here, you know, so I think it kind of fits well with practice. The EQ5D3L, that's a very attractive name for an outcome measure. It's an outcome measure. If any of you are into reading research articles, this is a tool that is used heavily in research, and I've realised I've incorrectly, it's actually the 5L, because it's 5 areas and not 3. Anybody who's read Philip Whitehead's work around the Bath Out project, he used the EQ5D5L as an outcome measure, and what that does, it's a self-reporting scale. It's fairly simple, and it looks at 5 areas of common activities of daily living. And looks at pain and discomfort and anxiety. As I say, it's used a lot in research, although I think there are a few places that also use it in practice, and there's a link there. And then there's the adult social care outcome, the ASCOT. Again, this is a self-completed questionnaire. Some of you that work in social care may have come across this. I think if you're in social care, you can access this free of charge, and it considers 9 questions around well-being and activities, and this is very much, as an outcome measure, it's very much focused on what impact the social care provision has had on health and well-being. Again, if you read Philip Whitehead's work around the Bath Out, he used this measurement, and what he was saying in terms of what customers were important to them in terms of the impact that adaptations have on health and well-being, it very much, those things that were important around dignity, independent, feeling clean, and they kind of linked and were very much aligned with adult, the ASCOT. So that's the adult social care outcome measure. Again, some of you might be familiar to that. What's nice about the that ASCOT measure is that they have tools that are designed for carers and people with learning disabilities as well, and it's just 9 questions around activities of daily living and what impact that what you've provided has had on health and well-being. Okay. Any questions about the outcome measure? As I say, I do apologise that I've not been able to kind of show you these tools in action, but hopefully you can go away and have a look at these in your own time. And as I say, I do know that these tools are being used out in practice in some areas.
Okay. Yeah, I think people are interested in these, and obviously they've got their own tools that they're trying. So we'll collate all those, and then we'll have quite a list of potential tools, I think.
Brilliant.
There was also one that Hack did for us a couple of years ago, looking at social value based on WebWEMS.
And what did that look at, Paul? What kind of concepts did that look at?
It was very much based on the kind of the well-being questions that you ask as part of the WebWEMS outcomes, whatever it's called.
Yeah.
And it worked really well for minor adaptations, but not quite so well for major adaptations, which a lot of these seem to, because you can get, I suppose, a good outcome from a grab rail, and it's really, really, really good value for money based on a 25.
And I wonder, Paul, if it's to do with, do you know what I was saying before about measure, is it sensitive enough to measure the change? So I know that often we'll put in, might recommend, say, bathroom adaptation, but if you use your measurement, then often the person will still need help, but actually they can do a lot more of the activity themselves that then makes them feel much more independent, much more confident. It's reducing the strain for the carers. And I don't think always some of the outcome measures for major adaptations pick up what on the surface is really subtle changes in terms of, so you've not had a big impact on independence, but you have actually had a real impact on kind of quality of life and how the person's feeling, and that all contributes to mental health well-being. So I just wonder with some of the major adaptations that some of those tools aren't sensitive enough, whereas I think something like with the EQ5D3L, I don't think it would necessarily show up that kind of detail, whereas I think the Ascot would show up and be more sensitive to those subtle changes, which are on, on the surface it may not look big in terms of changes in function, but in terms of impact on well-being makes a huge difference. I don't know whether people agree. So
I think there was some research from Australia that looked at the impact of kind of home modifications for the bathroom, and found that the biggest impact was on informal carers, and preventing carer breakdown rather than necessarily increasing independence for the disabled person all that much, or reducing domiciliary care is much more about the kind of informal carers in the home.
Because I know that if you get a chance to read Philip Whitehead's the paper that he published on Bath Out 2, which is the qualitative stuff, like one client said, I can just do it now. I'm not, I can just do it, and it's just not a hassle. And a lot of these outcome measures wouldn't necessarily capture that, but that has had a huge impact on that guy's independence and sense of well-being. So
Yes. A couple of people just asked, or Joanne just asked about paying for outcome tools. Certainly you can use the hacked one for free. I guess some of the ones that people are going to share will be available for free. And there is a little app called Impactosaurus that you can use for free, where you can add the questions in and get the initial answers, and then record the final questions a little bit later and see the change. So there is stuff you can do for free.
I mean, in the wonderful world, as you know, if anybody knows me, I'm very much an idealist and kind of very positive, and I think it would be great if we were all certainly in terms of the DFG, because obviously one of the things that we want to do is be able to show the impact. And if we're all collecting slightly different measures, then from an academic point of view, a research point of view, it's then really hard to kind of bring all those data sets together to be able to come up with some firm conclusions if we're all using different things. But that's a different presentation altogether. Right, just talking about how we can be using the data from these outcome measures. So I'll whiz through this because I appreciate that I've been talking at you for a long time. Okay, I think what we're not always very good at in terms of our outcomes is helping customers to see the difference that the adaptation has had on their health and well-being. So I think if we're using the right tools, I think they're a fantastic resource in terms of helping individuals understand what impact it has had on their health and well-being, and the impact the DFG process has had on their ability to do the everyday activities that are important for them. So I think it's really important that we need to be sharing the results from our outcome measures with the people that we're working with, so that they can have a better understanding of the impact that the DFG has had on their health and well-being. And that, again, hopefully that word of mouth then spreads the positive use of the DFG and going for a DFG. I think from a practitioner point of view, from a professional point of view, I think it's, and we should, certainly as an occupational therapist, I should be doing this anyway in terms of my code of conduct, is that I think these outcome measures are are an opportunity for us to be able to reflect and learn about how we've done an adaptation, and looking and reflecting and what we can learn from the next adaptation. So perhaps if we haven't had the outcome that we anticipated, it's an opportunity to kind of reflect and learn on that and take that forward to the next case. Conversely, if it's been a real success then, or has had unexpected outcomes, again, that's an opportunity for us to reflect and learn and take forward that practice, not only amongst individual practitioners, but amongst practitioners. So that's just some kind of softer side. Obviously, from an internal point of view, the internal reporting outcome measures are essential. So from a service level point of view, I think what the outcome measures allow us to do is evaluate the overall impact that our adaptations are having on health and well-being. As I said, and this kind of links back to my previous point, Paul, is that we're not just, I think previously we've been very caught up in outputs. So how many DFGs have we done? How many hospital admissions have we avoided? What we also want to be capturing is the impact it's had on health and well-being. So it's the overall impact that we had, not just the outputs, but also the outcomes that we've had on health and well-being. And I think, obviously reporting that to managers, being able to see the impact that we are having on health and well-being, so that we know when we're being effective in what we're doing. I think from a service development point of view, again, going back to my previous point, if we're looking at outcomes, it helps us to consider the effectiveness of different adaptations, different designs of adaptations, and how perhaps different parts of the DFG process might be impacting on the outcomes. So I think from a service development point of view, data from the outcomes are really important in terms of helping improve the delivery of the DFG. As I say, I think it would be really great to be able to capture sets of data on different types of adaptation, different designs of adaptation, so that we can use that kind of data to improve what we're doing. And again, looking at different parts of the DFG process and seeing if there's an element of the DFG process that is perhaps kind of hampering how we're achieving outcomes, if that makes sense. So using the data from an external reporting point of view, obviously in terms of reporting to managers, commissioners, we can use these to illustrate the impact that we're having at that individual level. Case studies, I always want to say vinaigrettes when I see that word, vignettes. So we can use case studies and vignettes, and they're a really powerful way with commissioners, with key stakeholders, to really promote the value of what we can achieve through, on that individual level, what we can achieve through the DFG process. And again, that's obviously from a public point of view, but obviously again from a commissioner's point of view, it's demonstrating the impact that we're having on a community's health and well-being through the DFG process. So that's how we can be using the data from these outcome measures to show that. And again, we can link the outcome measures with rate on investment, so we can then kind of do the cost benefits analysis to look at, you know, what impact the DFG is having on reducing health and social care costs, and you can get all the figures from the PSSRU in terms of, you know, what the cost of an OT assessment, what the cost of a hospital bed per night is, etc. So we can link the outcome measures and the results from the outcome measures and look at impact on return of investment and the difference the DFG is making to hopefully reducing health and social care. Right, you'll be glad to know that that is it. Obviously, we've got a little bit of time for questions. As I said, I'm leaving Salford on Friday, so I've put that email address down if you want to get hold of me. The reason it's Bronte is I live in Haworth, which is where the Bronte sisters are from. So that's my bit of cultural education for this afternoon. So if I stop sharing, has anybody got any questions? I can probably bring the questions up now.
Are you aware of any examples where health and wellbeing boards have influenced outcomes that are measured and evaluated?
I haven't. I don't know whether anybody else has.
Okay, well, if you have, pop that in the chat. Somebody else was asking about with the frequency of turnover of OT swapping from short to long-term teams, something by the time works have completed.
And I think this, and again, this is, yeah, so I think these are some of the practical issues that you really need to think about when you're choosing an outcome measure. So if it is a tool that's very much part of the process, then hopefully that data is captured as part of the process, because you might have personnel changing, but the process should remain the same, she says. And I think once again, we have to be open, we have to be transparent about what the practicalities are like out there in practice, so that we ensure that whatever tools that we're using continues to capture the data we want it to catch, even if we have those changes.
Do you think there's any difference between, I suppose, kind of tools where somebody just fills in a form, so it's a bit more, I suppose, objective, or do you, I suppose, could it be skewed if somebody asks the questions in a certain way if they're kind of asking them in person?
This is where, once again, it's about, this is where you have to make a decision about the reliability and validity of the tool. If it's a homegrown tool, then you're potentially building in bias. Obviously, if it's the person filling, it's like, I think I've just twig what you mean. I suppose, yes, you could build in, but the person asking the question could build in bias, because obviously if they're the one that's filling the outcome measure in, then you're potentially building in bias, which is why some of the self-reported tools are much better, because it's actually the person that is reporting on the outcome rather than the person who's done the adaptation interpreting what the person says.
Yeah.
I think one of the things I will say about this afternoon, and I should have said at the beginning, it's one of these workshops that I've probably created more questions than I've answered. But hopefully you now know the questions that you need to explore if you're going to be looking at bringing in an outcome measure.
And do you think there would be benefit in doing that a bit more centrally, so that everybody's kind of having similar outcome measures to kind of compare and contrast and benchmark?
Well, I think if you've got a recognised tool that everybody is using, so one of the things that when we had the Gen Home project, which was one of the things that we were looking at, was around outcome measures. When we look at big data, and when we're trying to convince government to invest in the DFG, if we've got big data, then we can use that to really see the impact that we're having with the DFG. The difficulty at the moment is that we don't have that big data, do we, Paul. Do you know what I mean? So I think if we did have an outcome measure where we knew that we were capturing health and well-being concepts that were important to the individuals who have to have adaptations, then I think that potentially has, and it was reliable and valid, and that it could really fit within the way that the DFG works. But again, we've got challenges because of the different way the DFG process works in different areas. Yes, I'm short answer, yes, it would be lovely to have one tool.
Yes, I suppose it was amazing how much it went up with next to no evidence, actually. So having some evidence would be amazing.
I suppose a lot of it, well, perhaps it is because it is this thing about common sense, but it's like anything, isn't there? If there becomes a challenge in terms of austerity, whatever, and we start to get cutbacks, it's about having that evidence base to support it. So I agree with you, Paul. Yeah. And
I suppose if there was one question or one outcome about adaptations added to the Better Care Fund, have you any thoughts on what that one question might be?
My brain's gone blank. I think I've got presentation fatigue.
I know we kind of discussed it during the DFG review, but it's quite tricky just to pick on one.
I think we've all got different perspective, isn't it? At the end of the day, for me, it's actually what the person, in terms of their health and well-being and the impact it has on them, that is the kind of key thing. So I'm just trying to look. I think that's really, because I think it depends where you're coming from, which perspective you're coming from. So I'm just going to get myself out of that one.
Okay, fair enough. And just one last one from Victoria. She was kind of talking about would there be benefit, do you think, in doing a much longer term kind of return?
Yeah, do you know what I think this is really interesting. I would love, and I know, so I keep going on about Philip Whitehead. He did go back, because often in research, in terms of they tend to be 6 months and 12 months. But I think it would be really interesting to do a piece of work to look at, the use of adaptations 5, 10, 20 years down the line. Again, it's about providing an evidence-based, is there something that we could be doing with the design of adaptations that mean that they last longer? I think about, if you think about the adaptations done for children, is there bits and pieces that we could be doing there? So I think if we could look at the longer term impact, both immediate, and I think the other thing as well, sorry, you can tell I'm getting really enthusiastic now and excited. I think certainly for some people, they have waited for so long to get, and Frances Haywood talks about this in her work. They've had to wait so long for the adaptation. They're just grateful for anything that is installed. And actually, it's only once it's installed and they've been living with it for any length of time, do they actually begin to perhaps see how the adaptation is truly working. So I think, again, if we could go back 2-3 years afterwards, so we can really understand, is there something about the design we could be doing differently? Is there something about the layout we could be doing differently? And I don't think we always pick that up 6 months, 12 months after the adaptations is installed. So I would agree with you. I think going back even 10, 20 years would be useful.
Chris Sneddon's just suggested going back 3 and 5 years. So maybe there's something in that.
I think I agree with you, Chris. I'm only saying that because I'm going to be working with Chris soon. So yeah.
Great. I think that's probably all the questions. We'll certainly go through the chat afterwards and see if there's anything else that picked up that we can share on the website.
And as I said, there's lots of useful resources on Foundation's website, on the RCOT website, and there's also that document I talked about, and I'll send Paul the link to that. Paul's also will circulate the PowerPoint as well, so you'll have the links that I've been referring to.
Yeah, so if you give us a few days, we'll put it all on a new page on the website, so it's all there for you.
Thanks ever so much, Paul, for the invitation.
Thank you, Rachel. That was great.
All right.
So thank you everyone for watching. As you sign out, there is a little link to give your feedback, which would be fantastic. But other than that, again, to say thank you very much, Rachel. That was brilliant, and we'll be back with another webinar in September.
All right.
Thank you.
Thanks, Paul. See you later.
See you. Bye.